I think that, in the evolution of endoscopic therapies, I think we realize that we still need our surgeons because we don't have an endoscopic way right now to fix a hiatal hernia. And if you take a look at people with reflux to the point where they are seeking some form of mechanical correction, most of those patients, a large percentage at least, will have a hernia of significance. And that'll usually need to be redressed. And so, the way that we do it at my institution is that, as you mentioned, a primary care would refer a patient either to one of my gastroenterology colleagues or to myself directly. And then we would do a workup primarily to make sure that we're not dealing with functional heartburn or some other condition, and to assess the anatomy, as we discussed earlier, as well as the physiology and the motility. And once we have that information, we would make an assessment about whether a hernia repair would be needed, and also if some modification of any wrap that would be done would be necessary given altered motility. And in those cases where I felt that this patient would need assistance of a surgeon, I have a close working relationship with my chief of surgery, and we have several surgeons in our institution that participate as well, and there are several faculty in my GI division that also perform endoscopic anti-reflux procedures. So, but we partner up with our surgical colleagues, and then we have them usually have an office visit with them to discuss what a hernia repair would look like, and then to discuss whether they would want to do a straight surgical technique, or perhaps an altered surgical technique, or a combined endoscopic surgical technique. And I think the best way to get surgical buy-in to this is to realize that no one approach is going to be perfect for every patient. And the more that we can provide a spectrum of options, the full spectrum of options, the more our patients are going to feel comfortable coming to us, and our surgeons are going to feel comfortable being part of the process and feeling included in this. So, and at that point, usually after my surgical colleagues see the patients, then we usually have a conversation to discuss what we think, and then pick a course of action moving forward.